Why is it so important for my surgical team to know that I have obstructive sleep apnea before an elective procedure? Why should that even be on their radar?
First of all, it's my job to keep you safe during the procedure. It's not just my job to put you to sleep.
I was curious about how you would describe the impact of anesthesia in terms of what it's actually doing with sleep.
We typically don't tell patients that they're truly sleeping. We don't classify it as sleep. You're not catching up on a good night's sleep per se with anesthesia.
So what types of complications is someone with sleep apnea more likely to experience?
Hello and welcome to Sleep is My Waking Passion, the podcast where we get real about sleep and how it shapes your life. I'm Dr. Alison Kole, a triple-boarded pulmonary critical care and sleep medicine physician who's learned to thrive despite having chronic insomnia. And now I'm here to help you do the same.
Hi there. It's time for another episode of the Sleep is My Waking Passion podcast. I'm your host, Dr. Alison Kole, and today I am very excited to welcome Dr. Christopher O'Mahony, a board-certified anesthesiologist. He practices here in New Jersey, which is my home base, and he has helped countless patients safely navigate surgery, including those who have obstructive sleep apnea. If you or someone you care about has obstructive sleep apnea and is facing an elective procedure, you really don't want to miss this episode. Dr. O'Mahony is sharing straight to the point advice about what to expect before, during, and after surgery, and what kind of essential questions you may want to make sure that you're remembering to ask your clinical team. Maybe we'll be answering some of those questions that you already have on the show, and why getting prepared can make a real difference in your recovery. So please stick around. This information could genuinely impact your health and peace of mind and is highly applicable to all of us because all of us should be getting our routine screenings. And so we will be exposed to anesthesia at one point or another. Welcome, Chris. Thanks so much for joining me today.
Thank you so much, Allison. As you said, I am a board-certified anesthesiologist. I've been in private practice for over 10 years. I've worked at hospitals and ambulatory surgery centers, and I'm a big fan of your show. I love the work that you're doing. You've had a number of very distinguished guests on your show, and I'm glad you made an exception and invited me this time. So thank you.
Stop. I'm so excited, so excited to have you. So, Chris, just to level set, because you had mentioned this before we got started, what types of procedures have you had experience with, or does it really run the gamut?
It runs the gamut. So anesthesia training would run the gamut. We're doing pediatric cases, we're doing geriatric cases, the whole age range. We're doing heart transplant, liver transplant, kidney transplant, burns, a typical anesthesia residency program, which typically it's 4 years, with 3 of those years focused on anesthesia. So we're really covering the full range of procedures in our training, and then some of us subspecialize further as we go on. I chose to remain a generalist, which means I do sort of a range of mostly adult patients. Again, outpatient procedures like colonoscopies, more involved vascular procedures, neurosurgery as well.
So you've really seen it all. That's what I'm getting from you.
I'm sure I'll have surprises in my future, but I've seen a lot so far, yes.
So I guess my first question would be, me as the patient, for example, why is it so important for my surgical team to know that I have obstructive sleep apnea before an elective procedure? Why should that even be on their radar?
First of all, I guess as the anesthesiologist, it's my job to keep you safe during the procedure. It's not just my job to put you to sleep. It's also my job to keep you safe. So I'm watching you the entire time to make sure if anything happens, I can correct any issues. So knowing patients' past medical history, no matter what it is really helpful for me to know all the details so I can make good judgments and know what to focus on. I don't want to get anything lost in the weeds. If there's, sleep apnea or a history of heart attack or something, I want to know about that so I can balance the anesthetic appropriately. In the case with OSA, anesthesia can make OSA symptoms significantly worse. We decrease people's respiratory drive. We make that collapsible airway even more collapsible. That trigger to wake up when we're obstructing, if we have sleep apnea, that's blunted by anesthesia. So a patient's ability to wake up and start breathing normally is going to be limited. So we're compromising all of that with our anesthetic. And so we really want to be aware of that so that we can make appropriate modifications to keep those patients safe.
A lot of patients are always curious because they may get out of propofol. And I've experienced this personally from my colonoscopy days. And they're like, wow, that felt like I had a good sleep. I know there's a lot going on, and I was curious about how you would describe the impact of anesthesia in terms of what it's actually doing with sleep?
We typically don't tell patients that they're truly sleeping. We don't classify it as sleep. You're not catching up on a good night's sleep per se with anesthesia. It's a different kind of sleep. We're not really going into that REM sleep where it's real, true, restful kind of sleep that we should be getting, or 8 hours or so a night. I mean, you're the expert. I'll let you quote the exact numbers that we should all be getting. But, that it's not really contributing to that. That said, many people do dream. We think that's more or less as they're going down or emerging from anesthesia. They may have some sort of recollection of some sort of dream. I've certainly had patients who've woken up, looked at me and said, "Oh, I had a dream about you, doctor." I'm like, "Oh, please tell." So I have had that. I had a woman tell me, give an elaborate story of, I picked her up in a Lamborghini. We went out to the clubs. We were dancing, so people have had very elaborate dreams under anesthesia, but it's not really for the whole time that we're inducing a true sleep-like state. It's more of how we describe it to people so they have a better understanding of what to expect, that they will go to sleep and that they will wake up at the end. If that's the intention, is for them to sleep through the whole thing. That's sort of what we try to describe to people to help it make it a little bit more easy for them to understand what their experience is going to be like, what they're going to remember, how they're going to feel.
And how does having either untreated, which could be because it's undiagnosed, but not necessarily, untreated or poorly managed obstructive sleep apnea, how might that impact the risks associated with anesthesia or surgery, for example?
So I would say there's sort of two sides to this coin. There's the risk of actually difficulty with the breathing itself. So as the anesthetic, whatever we choose, it compromises the breathing, decreases the respiratory drive, therefore their oxygen levels drop. That's obviously bad for the brain, bad for the heart. So there's that side that we're concerned about. But there's all the other systemic issues with sleep apnea too, and it's untreated. The high blood pressure, the coronary artery disease. For those of you who don't know, that's the blockage in the arteries of the heart that can predispose someone to having a heart attack, stroke, irregular heart rate, regular heart rhythms. So all of those issues can also be made worse by anesthesia, unfortunately. So your blood pressure can swing up, it can swing down under anesthesia. The stress of the surgery, of the anesthetic, can also predispose people who are high risk to having a heart attack to have a heart attack. So we want to try to mitigate all of those factors as best we can.
So what types of complications is someone with sleep apnea more likely to experience either during or after surgery?
So the big one is always the drop on oxygen levels. So decreased breathing, oxygen levels drop, carbon dioxide levels go up. Both of those could be dangerous. So again, we're doing our best to monitor those patients and do everything we can to minimize those risks. Also, patients with sleep apnea tend to have slower wake-up times than patients without sleep apnea. So in a longer anesthetic or a patient who has very severe sleep apnea, we can expect it may take a longer time for them to emerge from anesthesia and be up and awake and talking and safe for discharge.
If I have CPAP or whatever BiPAP or whatever mode of ventilation that my sleep doctor has assigned me to help me with my breathing, should I bring it to the hospital?
Yes, please. And label it as yours. No, we definitely want you to bring that. We don't always use it, but it is very helpful to have. If we have any concerns about your breathing after the procedure in the recovery room, we can use your bite block or your CPAP machine, provided we know how to set it up and we've discussed that with you. That can certainly help, especially if you're taking a long time to wake up. That can allow us to keep you a little safer in the recovery room. Certainly in an ambulatory surgery center where they probably won't have spare ventilators to use to assist you. So certainly please bring it. But again, when I have a patient with sleep apnea, I'm going to be extra cautious about bringing that patient to recovery. So I will try my best to have them awake before they arrive. So again, with that slower wake up, I want to do as much of that when the anesthesiologist, am watching them, making sure that they're safe. So you might be very awake by the time you get to recovery, and that's by design. We want you awake, we want you safe, and you might not need your CPAP machine, for example. But it's nice to have it just in case, for sure.
Oftentimes, with my background being pulmonary, some of the most difficult airways are typically those who have obstructive sleep apnea. And I was just wondering if that changes sometimes even how you might approach a procedure if you know kind of upfront that person has pretty bad sleep apnea, for example.
Absolutely. I'd like to sort of, maybe if we pause here, we can talk a little bit about the different types of anesthesia, because then sort of helps me put you down sort of a special pathway. Procedures can be done under what we call local, without any sedation. These are more minor procedures. For example, many of us have had dental work where we just get a little injection of numbing medicine, and we don't really need to be sedated for it necessarily. You can have light sedation or mild sedation where you get a little relaxing medicine, a little medicine to treat pain, but it's otherwise not too uncomfortable a procedure. For example, like having cataracts, many patients have that. They're awake, they're talking, but they're just lightly sedated, so they're comfortable. Then we progress into deeper sedation. Deeper sedation might feel like sleep. You might only remember going to sleep and then waking up in the recovery room. And, these patients are often very, very comfortable throughout the procedure. But it's not quite as deep as general anesthesia. General anesthesia, we go a little bit deeper, and that allows us to put a breathing tube, if we need to, in the patient's mouth, typically while they're sleeping, and then we can connect them to a ventilator to help them breathe throughout the procedure. With sleep apnea patients, deep sedation and general anesthesia are a bit concerning. We have to be a little bit more careful with which decision we make. With deep sedation, you may be in a position where you have a patient who requires a lot of sedation to keep them sleepy, but with their sleep apnea, they're so sensitive to the respiratory effects, they can't really breathe sufficiently in that state. The needed state of sedation is too deep for their respiratory status. They can't handle it. So then we would have to do general anesthesia in that case. The advantage of general anesthesia in that situation is the breathing tube is bypassing all of that soft redundant tissue that this obstructive sleep apnea patient has, and so we can keep them breathing much more easily. We can give a lot more anesthetic and without having to worry about the breathing aspect of it. Obviously blood pressure. There's other organs that are going to be affected. We still have to be careful, but that allows us to be a little extra. We can be a little bit more heavy-handed if we have to keep that patient safe and comfortable. Again, anesthesia, we're always worried about both safety and comfort and balancing those two. Pretty much every decision we make is safety, comfort, safety, comfort. How do I get that sort of sweet spot between those two things? And then there's regional anesthesia, which is another option. So that would be an injection in one side of your body to make part of you numb so that you don't feel any pain in that site, or minimal pain or minimal pressure. So for example, a C-section, an injection in the spine to allow a patient to give birth, through a C-section. The patient's typically awake for that, and that's the desired state. Surgery on the arm or the leg, we can do an injection to make that extremity very, very numb, so the patient can be very, very comfortable and not need as much sedation. They may still want sedation, they may still be a candidate, but they won't need quite as much. So that's sort of how we sort of approach this. Like, we have to think, okay, how is the sleep apnea going to act up? What kind of surgery is this? What part of the body are we working on? And how do we make all those things come together? So I guess to answer your question, the difficult airway. So sleep apnea patients can be more difficult to place the breathing tube. We may decide, well, let's just do that up front. We'll have extra people right there. An extra anesthesiologist might be right there to assist. We're all going to do this as a team effort. We have lots of equipment available. We're going to anticipate that this could be difficult, and we've got all of our equipment, and we're going to make this work smoothly. Or we might try to avoid instrumenting the airway at all. No breathing tube whatsoever. Let's do regional anesthesia. Let's just do light sedation if the patient's on board and it's a minor procedure. So you can avoid putting a breathing tube and have the patient breathe on their own, or you can be more prepared and have it be as much of a controlled setting. What you don't want to be in is the deep sedation, the patient's not tolerating it, and then you have to switch abruptly to general anesthesia. Certainly, I have done that. We do that if we have to. Certainly, if we're an undiagnosed sleep apnea patient who had no risk factors, and all of a sudden, we will then be able to do that quickly because we're very prepared people. Anesthesiologists, we do not like surprises, and we like to really be prepared. Every day I come into the operating room, I set up all of my equipment perfectly where everything's within arm reach. We're getting ready for those scenarios, but we prefer not to do that. We prefer things to be as smooth and easy as possible. And again, the more information we have on a patient about their medical status, such as sleep apnea, the better decisions we can make.
I'm just thinking of every 100% universally, anesthesia personalities are a specific type of personality.
Yeah.
You guys are always prepared. You know where everything is, but when you can be cool as a cucumber, and that patient could have a really messed up airway. I don't think I'm nearly as chill as a pulmonologist as you guys are. Now, granted, you're in those airways all the time, a lot more frequently than I am at the bedside, but yeah.
Yeah, I have been told by other people in the operating room that if it's the end of the world, they want to be by my side just because of how I'm like, okay, everyone, this is what we're going to do. All right, everyone, listen up. We've got a bit of a problem. This is how we're going to fix it. I need you to get that. I need you to get that. Oh, good. We already got that. I'm the person I want to educate everyone when I come in. So if I have a patient with sleep apnea, I'm already talking to the team. Oh, so this one has diagnosed sleep apnea. Do you know where all the emergency equipment is if I need it? Okay, great. You can help me with this. You can help me with that. All right, everyone, we're going to pause. We're going to, and I prepare everyone for the worst. So when it all runs smoothly, I look good, but B, more importantly, the patient's safe and everyone was prepared and it doesn't catch anyone by surprise. Because again, you're trying to be cool, calm, and collected. You don't want anyone to mistake that there might actually be a problem that we're trying to fix, or we might be in a more tenuous situation.
I love it. I am soothed by how you were talking about the airway. And I think every patient, every person listening who will eventually be a patient should also be hearing this. And it also raises the observation that I think we talk a lot more about obstructive sleep apnea openly. Maybe it was a discussion, and I know the anesthesia literature certainly flagged OSA as being a consideration, but it wasn't that much of a consideration amongst surgeons until I would say a few years ago. And that is when, it was sort of like, oh, we sent them home and there was some issues with their airway, and then we had to give them pain medication postoperatively. So what I was curious about was, with this change in dialogue, has that impacted, for example, when you talk about regional anesthesia? One of the things that surgeons have flagged to me is that they'll actually potentially choose that even for shoulder replacements, for example. That's the example where I've seen it really obviously. And it's done very specifically to reduce the amount of oral pain medication to further help the patient remain safe. So it sort of impacts that recovery piece.
Yeah, that immediate recovery period where these sleep apnea patients are most vulnerable, where they've been exposed to whatever anesthetic in the operating room, they're taking the most pain medications, and now, okay, you're safe, your oxygen saturations are good, if you go, have fun at home. We want to keep that pain level low so they're not taking more opioids than narcotics than they need to. So the regional anesthesia really does help with that. Certainly can be a beneficial aspect, a beneficial pathway to pursue for a lot of patients, given, certainly selecting the proper patient and the proper procedure.
It's interesting to watch patients that I have taken care of, and they may have gone for their colonoscopy or what have you. Any of the various, some of them, you almost feel like they're bionic. Like they've had this knee replaced and then they're going for this, and then they've had this and that. And so they've had multiple surgeries, and they'll say, well, why is my sleep apnea such a big deal now? And it's fascinating to me to explain that to them. And I was curious as to when you started to notice the shift. I love the fact that we're flagging it, but it's curious for me. And maybe my perception is I'm just talking to surgeons, having less conversation with the anesthesia. So
when did the shift happen with surgeons starting to care more?
When did you start to notice the shift, or has it always been on your radar, so it's hard for you to tell?
It's always been on our radar. It's one of those things. Again, we like to, as anesthesiologists, we like to be prepared. We're going to treat, even if you don't tell me you have sleep apnea, I'm going to be looking at your risk factors and thinking, okay, how can I tailor to my concern that this patient may have undiagnosed sleep apnea? So we've always been, certainly started my training, we were taught about this, that this is a concern, that this is an issue. Certainly in outpatient procedures, we've got to be concerned about it. But it's one of those things the prevalence is so high. We deal with it so much, whether we know we're dealing with it directly or not. We do deal with it, and we're used to difficult airway and patients responding in a less than favorable way to multiple anesthetic agent categories. So to me, it's always been on my radar. Certainly the surgeons have gotten better as I practice. And I think they are aware of this, especially the ones in sort of a small outpatient facility. They know what a challenge it can create. And I think there's appreciation for what we can do to sort of fix any issues that can come along. And there's more respect for anesthesiologists for our ability to sort of move the process along and keep the patient safe. I haven't noticed a dramatic shift. I was lucky. I've worked with some surgeons who were very, very accommodating, and right away from, first job out of training, I had surgeons who were like, okay, everyone stop. Chris is about to intubate the patient. We think they have sleep apnea. Everyone stop. I hear people talking, give Chris his space. So I had a lot of, I was very well treated by a lot of surgeons who would, even a surprise sleep apnea case, they got it right away. Like, hey, I think this patient has sleep apnea. I know it's a young woman who's thin and healthy and you never would have thought, but like, look how she's breathing. Let's change our plan right here, right now, before this becomes a problem. Let's keep her safe.
Oh, that's so wonderful to hear. It really is.
I've worked places where they really they all stopped and they all took the airway very, very seriously. I've worked places where it's not quite where I would like it to be, but right out of training, there was a few places where it just oh no, this is how it should be. Everyone stops. They made sure that there were multiple nurses in the room. So if I needed a hand, there were multiple people who could stop what they were doing and run and get anything that I needed. Like, they were so prepared and just watching me. Like, you're just watching you like a hawk ready to help. And I loved that. And it was so nice. And I've always tried to replicate that in my practice and cultivate that when I work at a new site with a new team. And I try to build that sort of rapport of like, okay, these are the things that you can be doing to help me. What can I be doing to help you? How do we communicate better? How do we all get on the same page? And sort of building that respect and trust within the practice.
If there's someone listening here and they're like, well, I'm not sure I have sleep apnea, but, I've got my colo scheduled soon and, I've got some stuff going on. Are there any physical attributes that you want to highlight that just by looking at the patient, you're like, oh, dude, you probably have sleep apnea? I haven't seen your sleep study results, but I'm kind of sure,
And I hate to categorize people because we'll get people who you think that they have all of the, they must have sleep apnea in the back of your, you're like, okay, that's probably because they've got all the risk factors. And they do so smoothly with sedation, deep sedation, like, oh, wow, I question that. I'm not, so I hate to put anyone in any sort of box right away. But certainly from a difficult airway perspective, from the challenges that I see, not necessarily the more systemic issues, because those are all pieces that I'm looking at, but it's not something I don't visualize. Like, I don't look at someone like, you have high blood pressure, but I can look at someone and say, probably sleep apnea. Again, the width of the neck, larger neck circumference, certainly I pause and I think that person may have a difficult airway or be more difficult to ventilate or more issues, even if they don't have sleep apnea per se at home. They may appear to be more of a tricky case, like a sleep apnea patient, when they're with me.
Right.
So that's sort of the big one. Certainly older men tend to have more difficulty, I find, with breathing and under anesthesia, probably more correlating with their sleep apnea risk. But those are sort of the two things I'm a little bit more, the spidey sense is tingling a little bit more. But again, I've had young, thin women who just no one would think that they fit the classic mold for sleep apnea, and they almost definitely have it. You're just looking at how they breathe when they're sleeping. Like, okay, yeah, you need this. You need a sleep study.
And then my other guess would be things like, and this is something that I look for too in the office, so I'm going to flag it. One of the things that I think can be helpful is what we call the Malampati score.
Oh, yeah. So that, yeah, sorry, yes. Sorry, when you first asked that question, like, she's asking about the Malampati score, but I digressed. Yes. So we ask people to open their mouths, stick out their tongue, and I get them to say when they relax. That's sort of the snapshot that I.
And then it relaxes, yeah. Right?
So it depends
if
on
you
how
need a visual of my tongue, everyone.
If you want to see my uvula, here we go. No, we're not going to do that. This is a professional show, but we're trying.
Professional adjacent.
Right? So yeah, I know everyone asks me, why are you doing this? So that does give me a sense of how difficult an airway, how difficult they will be to ventilate, how much trouble I may have with their ventilation in the procedure room. And yes, I think of that as correlating most likely with sleep apnea per se. Yes, the Malampati score is something that we anesthesiologists are very obsessed with. If there's one thing about your body that I want to know, it's probably your Malampati score.
And, other things too, even if they weren't, you'd get a sense from it just from them sticking their tongue out, which is essentially being able to take, just with a little light, a look in the back of the airway. Yeah. Tongue size, I think, really matters. And then jaw mobility is something else I look for. And also if they've got a bit of an overbite. Yes.
An overbite much more concerning than an underbite. So yeah. So how they look in profile. And again, the thyromental distance. So basically how much space, how many fingers can I put beneath your chin without pressing into your neck? The more fingers I can place, the more likely you are to be easy to ventilate, easy to utilize, put an airway in your mouth. But, again, it's all relative. We take the piece of all of that. But the Malampati is the one we're the most concerned about.
You're taking me down memory lane through my anesthesia rotation, which was way too long ago. I'm like, oh, yeah,
it's a lovely
fingers.
stroll,
I
isn't
forgot
it?
about the fingers. Yeah. A lot of folks now with the advent of GLP-1s. So any weight loss, really, we know, improves obstructive sleep apnea for many people. It's not universal. And again, you point out the thinner, younger lady, for example, who may not fit the mold. But a lot of sleep apnea, a big risk factor that we can improve with weight loss is obesity. And these GLP-1 medications, the one that's currently approved for obstructive sleep apnea is tirzepatide. But any of these weight loss medications, they basically work either in the brain, in the GI tract, multiple areas to help regulate intake, and part of that regulation of intake is slowing GI motility.
Yeah.
So I wanted to know what, is the general consensus among anesthesiologists, and is there, any kind of guideline or anything as to what you need to do to kind of reduce the risk of, hey, I did everything I was supposed to do. I didn't eat before my procedure, but I might aspirate, and then that goes into the lungs. It causes inflammation. We call that aspiration.
Yeah.
That's no bueno. We don't want that to happen.
No. So I guess, so just to back up, yes, that is why we have you fast. It's not because we're mean people. It's not because we like to make you starve. It's because we want your stomach to be as empty as possible, your GI tract as empty as possible before we induce anesthesia. Because especially with deep sedation or general anesthesia, once you go to sleep, there's anything sitting in your stomach, it can come back up, you can vomit it, and because you're sedated, you're not able to protect your airway, and that can go straight into your lungs, and you can have a horrible aspiration pneumonia. This can require, weeks in the ICU. This is no joke. This is a really serious complication. I would rather have you vomit all over me than have one drop go in your lungs. That is how bad a complication this is. I'd rather have to change my clothes twice a day with people vomiting on me than have to deal with one aspiration pneumonia a year. Like really, we really don't want to see that. We want to do everything we can to avoid that. That said, these medications, a lot of people are on them. A lot of people are seeing benefit from them. So how do we balance all of that? Because these are slowing down GI motility, or definitely, where we're concerned that a patient on a GLP-1 is going to be more likely to have food in their stomach. So the guidelines are there, but we also have to tailor it to patient and procedure. So risk factors, what dose of medication they're on, how are they taking it? Is it a weekly injection? Is it an everyday pill? All of these GLP-1s, it varies, and then the patient's individual risk factors. So it's hard to come up with a hard and set, like, this is what we do every single time. Every single anesthesiologist and every single procedure for every single patient will do this. It is going to vary from case to case. So there's room for clinical judgment there, where we have to decide what's going to be safest for the patient. And it's going to depend on the type of anesthetic too, if they're at how high risk they are.
For example, at the institution where I had my colonoscopy, the anesthesiologist space, like if you're taking an injectable like tirzepatide, we generally, which is weekly, we generally say stop for 2 weeks. Is that a general rule of thumb, or does it really depend, as you mentioned, specifically on the procedure? I thought that was quite conservative, but I'm like, heck, it's also a pretty safe procedure that it would be better to, you can still resume your same dose. So it's not like they're making it so that it's going to be an issue for you in terms of like where you start off again, I guess, with the medication. Yeah.
There's also the people who are on the GLP-1s for the glucose control, that just sort of skipping it willy-nilly might cause them more problems. So we're trying to balance all of those things. 2 weeks, I would say, is certainly, if someone told me that, I'd say, okay, you're being conservative. Other places it might be a week. And again, the daily oral doses, sometimes it can just be 1 day. They just don't take it on the day of procedure. So, I've seen all of that. And, these are a relatively new class of medication. So the guidelines are also evolving. So I don't want to go on record as saying, oh, this is how it's going to be. So if you have a colonoscopy 2 years from now, Dr. O'Malley told you that this is what it's going to be. No, it's, again, it depends on, again, there's, what are the patient's risk factors too. And again, the procedure are going to matter. So, I don't want to quote any specific facility.
But I think that's a really good point in that it highlights what we know about, guidelines. We have these general rules of thumb that we follow, but then the science changes a lot faster than the Q10-year guideline updates, which is often, at least in the sleep world, I can tell you, it seems to take about a decade sometimes to get some of these things updated. And The other thing, too, is, yes, we are not directly telling you this is the protocol that you use or anything. So I want to make that clear. But you're also highlighting the importance of having that dialogue. This is why this is a topic of conversation on this show, because you should not be looking at it as an unusual. I want these conversations to become usual and not unusual occurrences. And that's what I emphasize to people, even when I'm talking to them, across the country, if I'm talking to other providers, even have that open dialogue, because just like you have that relationship with surgery, I've had relationship with surgery that has strengthened over time with my background in sleep medicine. We are really all part of this ecosystem that works together in an ideal situation to get our patients to the safety line and to do everything that we need to do medically to maximize their or optimize their health, including preventative type of procedures. But also, we want them to have a good outcome and be around too. We want to do no harm. We actually take that oath seriously.
We really want the patients to be safe, and we want to balance all of the factors. And it's you also don't want to be canceling people's procedures unnecessarily. Well, I took my GLP-1 2 months ago. Well, we're going to cancel you for that, unless there's a real good reason that there were complications from it. You know what I'm saying? We have to be cautious, and we want to know all of your medications, period. One challenge with the GLP-1s is that it's an injection, so people sometimes don't remember that it's a medication that they take. I'll get lists of oral medications, but they'll forget all the injections that they're taking. And so the GLP-1s will be on that list. So I actually ask, any injections for weight loss or diabetes? Because I want to know specifically anything and the whole list, because anything you take in theory might react with something that we do. And we want to really have that complete list so we can see the whole picture. It's not just the GLP-1s that we're worried about. We want to know everything. What medications have you missed? What medication are you supposed to be taking now that I should be giving you an equivalent in the operating room to keep you safe? We really want to know everything that you've been taking. So having that list when you show up is really, really helpful. And often people say, well, it's in the system. I'm like, well, it's in another hospital system that you've had a procedure. I don't have access to your record. I can't. I really want you to have the list with you today, right here for me, please, so I can make really good judgments and informed decisions on how to care for you. So that's definitely bringing your whole list with you on the day of surgery and telling people beforehand, because there's so many other medications leading up to surgery that, take this, don't take that, skip this the day of procedure, don't take this for 7 days. That, we want to be able to get you as ready as possible for procedure. We don't want any complications. So knowing the full list of medications, I think, is the most useful, regardless, even if it goes beyond just the GLP-1s.
Okay. So we've gotten through the procedure safely.
Okay.
I've got one final question that I'd like to ask you, which is, are there any signs or symptoms after surgery that should prompt me to seek urgent attention given my obstructive sleep apnea? Okay. I'm using that very deliberately because any surgery can have a complication related to bleeding, swelling, fever, etc. That's not what I'm referring to. I'm referring to specifically about anything to think about with the obstructive sleep apnea that should prompt a more urgent reach out to medical professionals.
So, again, as we've said before, the decreased breathing, the decreased ventilation, not breathing as well, but that can present as being over-sedated. If a responsible adult who's at home with you looking after you is noticing that you're not waking up quickly, they're nudging you and you're just snoring deeper, actually hear you obstructing or difficulty breathing, those are all very concerning. You probably need to go to the hospital for that or see a physician in some way. I would call the surgeon if they have a recommendation, if they want you back at the hospital, back at the surgery center where you were at, but you need to seek medical help immediately if things are getting worse in terms of your, cognition, you're less awake, or difficult to get you awake, or if difficulty breathing or sleep apnea just looks worse. We definitely want you to seek medical attention immediately for that. That is why we request or insist, I should say, that you have a responsible adult with you after same-day surgery. You should go home with someone who can look after you. You can be at their home. They can come to your home. We don't really care about that, but it needs to be a responsible adult looking after you. We do have patients who lie about that, and then we hear the jingle of their car keys, and they try to drive themselves home. And we don't like that. That's not safe. You've been sedated. You're not under the influence. We don't really want you driving. at least not in my neighborhood. We also don't want, especially with sleep apnea patients, we want someone there with you to see, because you go then, you have your surgery in the morning, you go home, and then you lay down and take a nap, fall asleep in front of the TV. Someone should be there to make sure that you're breathing okay, especially in that first initial stage. So that's why we really push for that. That's why we insist on that. If you have difficulty finding someone, tell us early so we can help you find a solution to this issue. No, you cannot take your anesthesiologist home. We're very friendly people, but you can't take us home with you. But we can help find some solution to this, be it that you stay in the hospital overnight or something. I don't want to, I don't want to supply the answer that your surgeon and their team will be able to come up with, or the anesthesiologist will be able to help you with. But that is why it's very important to have someone watching you, just for signs of oversedation, too sleepy. It's increasingly difficult to wake you up. Worsening of your snoring, people can actually hear you obstructing. That is all very concerning, and we need to have that addressed. I will also say that with sleep apnea, we're more likely to have issues in especially those first 3 days after anesthesia is sort of the convention that I've been using. So if you do use CPAP, even if you just use it intermittently, if you can make a special effort to use it those first 3 days. So Monday morning surgery, Monday night, Tuesday night, Wednesday night, special effort to use CPAP. Don't throw it away. Please continue to use it after that, but special effort to use that to keep you safe.
Dr. Chris, this has been so fun. Thank you so much. Thank you so much. And for my listeners out there, share this with someone who needs to hear it. If you think of a question that I have not asked, I have a friend who's an anesthesiologist. Please let me know, and I will make sure to get you an evidence-based answer. All right. Have a great one, Chris. Thank you so much for your time today.
Thank you so much. It was a pleasure.
Struggling with sleep? Dr. Kole is here to help. Whether you need a comprehensive sleep coaching program, suspect you have sleep apnea, or simply seeking a second opinion, she's available for consultation in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 10-minute review of services today to find out which visit is right for you at AskTheSleepMD.com and start your journey to better sleep with a trusted sleep expert.
Please be advised that the Sleep is My Waking Passion podcast is for entertainment and educational purposes only. It does not constitute medical advice. Always consult your healthcare provider for personalized guidance. For my full disclaimer, please visit AskTheSleepMD.com. And while you're there, don't forget to sign up for my free newsletter. Sweet dreams and happy listening.